Welcome everyone, and today we are going to finish off the skeletal system with the appendicular skeleton. So that's going to be part 2 of our skeletal system, and then we're going to finish off the entire skeletal system with the joints lecture as well this week. Alright, so today we're going to be talking about girdles and limbs. So when you think of the appendicular skeleton, think of appendages, right? So our arms and our legs. But our arms and our legs have to attach to our body somehow and attach to that axial skeleton. And that's where the girdles come into play. So our pectoral girdle is going to be our shoulder and our collarbone, and it's going to attach the upper limb, or our arm, elbow, and hand, to our body, to the torso, or to the rib cage, right? And then the pelvic girdle is going to be the pelvis and the hip, okay? And that's going to attach the lower limb to the sacrum, okay, or the axial skeleton, right? And the lower limb consists of the leg, the knee, and the foot. So let's go over again a little bit of the appendicular skeleton. Okay, so this is pretty much what we just talked about. It's just kind of written out for us. So the whole point of the pectoral girdle is to attach the upper limbs to the trunk. The pelvic girdle attaches the lower limbs to the trunk. And the cool thing about the appendicular skeleton is that the upper and lower limb share the same structural plan, which means that there are similar bones in the upper and lower limb. They just differ in their function and their names and things like that, but the structural plan is the same. Okay, so let's start with the pectoral girdle first. And the only two bones involved in the pectoral girdle is the clavicle and the scapula. The clavicle is also known as the collarbone, okay? And the thing about the pectoral girdle is that it does not completely encircle the body. When you think of a girdle, right, you kind of think of something that encloses or wraps around the body. And that's not really the case with the pectoral girdle because the scapula in the back don't come together. Okay, they're not attached to the spine in any way, but the clavicle on the front side, on the anterior side, are going to attach to the sternum of the rib cage, but that's it. Okay, so if we look at that clavicle, and the medial end, or midline, right, medial, is going to attach to the sternum. So we call that the sternal end of the clavicle. And then we also have the lateral side that's going to articulate with the scapula. And we call that the acromial end because it articulates with the acromion of the scapula. Okay, and we'll learn about that in a minute. Okay. So really the whole pectoral girdle only attaches to the axial skeleton at the sternum. So those scapula don't attach at all, they just kind of glide over the back of the rib cage. Now, what are some functions and features of the pectoral girdle? Well, we have a lot of muscular attachments in the shoulder, right? So many muscles attachment for that upper limb, the upper limb muscles. It's very light and very mobile, right? That scapula has a lot of mobility. But what happens when you have a lot of mobility is that you have a lack of stability. Okay, so this is a ball and socket joint at the shoulder, and we'll talk more about ball and socket joints, but there's a lot of mobility within this joint. And that scapula can move very freely because there's no bony attachment back there, it's just all muscular attachment. So lots of movement in the shoulder, but very little stability, which is why we dislocate our shoulder a lot of the times, right? Lots of force coming through those upper limbs into the shoulder joint and in through the clavicle. We'll talk a little bit more about that as well, right? That's why we break our collarbone a lot. So let's talk a little bit more about the clavicle. So we said the sternal end is going to articulate with the sternum, right? So sternal end, right? Sternum. And it specifically articulates with the manubrium. So the manubrium is that top part of the sternum, okay? And then the acromial end articulates with the acromion of the scapula. And we'll talk more about the acromion and the scapula in a minute when we talk about the scapula. But again, we have a lot of movement and everything in the upper limb. It does hold the scapula and arm in place laterally, and it only attaches at the sternum, so that's really the only bony attachment of the whole pectoral girdle. And so what happens is when you transmit all those compressive forces from the upper limb into the axial skeleton, it goes all through the clavicle. And so this is why we have so many stress and compressive fractures in the scapula, or excuse me, in the clavicle, is because of all that compression force going through it. Okay. So now if we look at the scapula, it lies on the posterior surface of the rib cage, right? So it's on the back side, and if you look at how the shape of the scapula is, there's one side that's flat and one side that has a spine or a ridge on it. So the flat side is obviously going to go against the rib cage, and then the spine is going to be the posterior side. And then if you also look at it, it has a couple of borders and angles. It looks kind of like a triangle. So if you follow the borders, so if we orient ourselves, and this is the right scapula, and we're looking at the posterior side of it, okay, let's draw our triangle, right? So it looks kind of like a triangle. So this is going to be the right arm, right, coming down off the shoulder. And if we see, this is going to be the superior side. So then we have a superior border up here. Okay. We have a superior angle here. So this is going to then be the medial side, which is going to be towards the spine, right? And then you have a medial, so that's the medial border. We have an inferior angle, right? If that's superior, this is inferior. And then we have a lateral border, because this is towards the lateral side in the limb, okay? So those are our angles and our borders, okay? So just if you think of it like a triangle and you can orient yourself on a right or left scapula, then you should be able to get your borders and angles, okay? So now what kind of landmarks do we want to know about on the scapula? So for the clavicle, we only had the ends, right? We had a sternal end and an acromial end. So on the scapula, we have a couple more ridges and notches and things like that that we're a little more worried about. So in blue, I have circled the projections. Okay, so the acromion we've seen before, that's the one that attaches to the clavicle. Okay, here's the acromion. So this is the posterior aspect, and this is the anterior aspect. So if you notice, the anterior side has a flat surface, right, versus the posterior surface has a ridge, or what's called a spine. So that's another projection, and it's for a lot of muscle attachment. Okay. And then we also have another projection up here called the coracoid process. Okay. So the coracoid process has to do with the joint. It does not attach to the clavicle. Okay. So I know it's kind of confusing with the coracoid process and the acromion, but if you remember that the clavicle has the acromial end, then you know that that's the one that attaches to the clavicle. And then we have a couple depressions, right? So depressions are going to be indentations. So if you look, we have where the head of the humerus comes in and makes the shoulder joint, and that's the glenoid cavity. Okay. It also is creating that lateral angle up here. Okay, we didn't quite talk about that one. So that's where the joint is going to happen, is at that glenoid cavity. And then if we look at the scapula and these flat surfaces on either side of the spine, you have one that's above the spine and one that's below the spine. So that's going to be our supraspinous fossa, because fossa is going to be a term for an indentation. And then we have an infraspinous fossa, so below the spine, and that one's a little bit bigger, right down here. So that's the infraspinous, and here's the supraspinous. And again, this is a big place for muscle attachment. And then if you flip it over and look at the anterior aspect, you have this huge flat surface, and that's the subscapular fossa. So sub kind of meaning below or under. So it's under the scapula, right, on that anterior aspect. So this is just all those pictures put together. And you can see the glenoid cavity a little bit better because you have a lateral view of it. So that's where that joint is going to be for the shoulder. And then you can also see a little bit better the difference between the acromion and the coracoid process. Okay. So now let's work our way through the upper limb. And luckily for us, with the limbs, we have a right and a left, and they're the same, except just mirror images of each other. So we can learn just the bones of one and apply it to the other. And there are tricks to determine if it's a right or a left arm just by looking at the bone. So there are certain landmarks that we can use. So the upper limb is going to be broken into groups of bones, and that's going to be the arm, the forearm, the wrist, and the hand. And so the first part's going to be the arm. Even though a lot of people refer to the whole upper limb as the arm is really just the region between the shoulder and the elbow. And there's only one bone there, and that's the humerus. And it's the largest and strongest bone of the upper limb. And there's lots of attachments for muscles, right? If you think about all your upper arm muscles, right? Your all those that we're going to learn when we get to the muscles, right? A lot of people know the biceps and triceps. Those are some of the bigger ones, but there are some other muscles as well. And there's two articulations. So the humerus articulates with the scapula at the shoulder, right? And at the radius and ulna at the elbow, okay? So now let's go through our bone markings of the humerus. Here we have the anterior or front view and the posterior or back view of the humerus, okay? So in blue, we have some projections. So we have the head of the humerus, which is going to articulate with that glenoid cavity of the scapula and make that shoulder joint. Then we have the greater and lesser tubercles, which are going to be some muscle attachments. And then we have the deltoid tuberosity, which is kind of harder to appreciate. It's a little bit of a ridge, and that's a muscle attachment as well. And then that's, so that's the proximal end, kind of middle of the shaft or the diaphysis, and then we have some down at the distal end. So we have the medial and lateral epicondyle, which are going to be little projections coming off to the sides, okay? And those guys are going to be attachments for ligaments of the elbow. And then we have these two kind of rounded, smooth areas, which are going to articulate with the radius and ulna of the elbow, or to create the elbow joint. And that's the capitulum and the trochlea. The capitulum is a little more rounded and is going to articulate with the radius. And then the trochlea looks a little bit more like an hourglass. And that one's going to articulate with the ulna. Now we do have some depressions as well, not as many, but some important ones. The intertubercular groove essentially just runs in between those two greater and lesser tubercles. And then we have two kind of deep indentations on the distal end. One is the coronoid fossa on the anterior side, and then the olecranon fossa on the posterior side. The olecranon fossa and the coronoid fossa are both for the space for the ulna. So when you bend your elbow, you have some projections on the ulna that you don't want to rub against the other bone. So there's an indentation to allow for the bending of the elbow. And the olecranon being the bigger one because that's the point of your elbow, the olecranon that we'll look at. So you need a big hole or a big space for that olecranon to fit into. So now let's look at the forearm. So the forearm is made up of two bones. And remember, we're always talking about everything in anatomical position. So if you have your palm facing forward, which is in anatomical position, the radius is always going to be on the lateral aspect, and the ulna is always going to be medial. So that's how we talk about everything. And we create some articulations, right? We have the elbow joint, which is going to be proximal with the humerus. And then at the distal end, we have the wrist joints with those carpal bones. And the two bones, since we have two bones together in the forearm, they're going to articulate with each other as well and create these radial-ulnar joints, proximally and distally. And then there's another interesting structure that holds the bones together, and this we see in the leg as well, and it's called the same thing. So the interosseous membrane. Okay, so the interosseous membrane is going to be a ligament of connective tissue that connects the two bones together. So there's movement in between the two bones, but it doesn't allow the bones to separate from each other, because that would be bad, right? Have your two bones separate from each other as you rotate your arm or your forearm. So let's talk about the ulna first. Okay, so it's really the bone that's responsible for the elbow joint with the trochlea of the humerus, and it really doesn't play much of a role in the wrist. Okay, and that's going to be vice versa for the radius. So if we look at some landmarks, in blue again I've got the projections. So we talked about that point of the elbow or the olecranon. So that's pretty important. That's, you know, when you feel that point of your elbow, you hit it on something, right? Your funny bone, that's the olecranon. Okay. And that's on the posterior side. And then on the anterior side, you have the coronoid process. Okay, so that's this little projection right here on the front of the ulna. And then you have a styloid process. So you have a styloid process on both. So you have an ulnar styloid process and a radial styloid process. So we'll talk about that when we get to the radius. Then we have some depressions. So where that trochlea fits up for the elbow, we have a trochlear notch. So that's where it's going to fit with the humerus. Okay. And then we also have a radial notch, which is where the radius is going to sit right there. So that's where the head of the radius is going to articulate with the ulna. Now let's talk about the radius. So it's more lateral in anatomical position, and it's going to articulate with the humerus at the capitulum, but it doesn't have much to do with the movement of the elbow. That's going to be the ulna, but it does have more wrist movement. So distally, it's going to articulate with the carpus, and it's going to really contribute to the wrist movement with the carpal bones. So what are some landmarks on the radius? So we have a head of the radius. That's going to articulate with the capitulum. We have a neck and a radial tuberosity. So it's just this little bump right there, okay, for muscle attachment. And then distally, we have that radial styloid process. So again, we have a styloid process on each, and they're both distal. And then we do have one depression, so we have the ulnar notch of the radius, which is going to articulate with the ulna. So we said there's two joints between the radius and the ulna, proximally and distally. Okay. So now if we just look kind of how these bones fit together, and we'll talk more about the joints in the joint lecture, but this just gives you an idea of how the capitulum and trochlea fit with the head of the radius and the trochlear notch essentially of the ulna. Okay, so inside is the trochlear notch, but that's that coronoid process right there, and that's going to fit up in that coronoid fossa when you bend your elbow. Okay, and then you have your big olecranon projection that has to be able to fit in that olecranon fossa when you bend your elbow, right? So this just kind of gives you an idea of what it kind of looks like. And then distally, you can also see kind of where it articulates in the wrist as well. So here's the radius and here's the ulna. Okay, so you can see there's a lot more surface area for articulation in the radius for the wrist. So a good trick is radius has an R in it, and then wrist has an R as well, versus the ulna has an L in it, and elbow has an L in it as well, to remember which bone articulates more in which joint. So now let's talk about our hand. So we normally don't think about the carpus as being part of the hand, but essentially the hand is made up of the carpus, or the wrist, the metacarpus, which is your palm, and the phalanges, which are your fingers. So let's first talk about the carpus, which is your wrist. And there's 8 little bones that make up your wrist, so carpal bones. They're about the size of a marble. And essentially they have some movement, which they slide across each other to move, okay? And so if we see, there's kind of 2 irregular rows. Okay, so if we start lateral to medial, we can name each of these bones. And if you always think your thumb is always going to be lateral, right? If your palms are facing forward in anatomical position, we start at our thumb and work medial. So scaphoid, lunate, triquetrum, which I know that's a weird word, and pisiform. Pisiform kind of sits on top of the triquetrum. That's your proximal row, which is more towards your radius and ulna. And then you have your distal row, which is the trapezium, trapezoid, your 2 T's, okay, capitate, and hamate. Okay, so you can name all 8 bones in the carpus. Okay, so the metacarpus makes up your palm. Okay, so it's going to articulate with the carpus, and then it's going to also articulate with your phalanges. Okay, so a lot of people forget about the metacarpal bones and just start naming your phalanges, but we can't forget about those metacarpals. And they're pretty easy to, because they don't have individual names, so they just have numbers, so they're pretty easy to number. So if we remember again, our thumb is going to be lateral, so we always name lateral to medial. So this is going to be metacarpal 1, 2, 3, 4, 5. Okay, so thumb is always 1, and then you work your way medially. Okay, so that's pretty easy. Okay, but we just can't forget that these are the metacarpals and not the phalanges. Okay, so they're the ones that articulate with that distal row of the carpus. Now the phalanges, we number them the same way, except that we are missing 1 phalange in the thumb. So each finger has 3 phalanges. So if we say this is 1, right? This is 2, and this is 3. Right? Now we're missing the middle one in the thumb. So we see we have 1 and we have 2, but we're missing that middle one. Okay, so this row is called the proximal phalanges. This is the middle phalange, and this is the distal phalange. Okay, so the middle is what we're missing in the thumb. So it's just distal and proximal. And again, we number them 1 through 5, thumb to pinky, right? Okay. So that's it for the upper limbs and pectoral girdle. So now let's move on to the lower limb and the pelvic girdle. So unlike the pectoral girdle, the pelvic girdle is a true girdle in the sense that it encloses the body. So obviously the pelvic girdle is going to attach those lower limbs to the spine, but because it does enclose, we do support some visceral organs, some pelvic organs in there. And there are some very strong ligaments in the pelvis, and the lower limb is attached very well to the pelvis. So even though we do have a lot of movement in the lower limb, there's less movement than we have in the upper limb. But the upside is there's a lot more stability in the lower limb. So if you think about it, there's a lot more compressive forces coming through the lower limb into the pelvis and into the spine than there is in the upper limb, right? So we have to be quite a bit more stable in the lower limb and in the pelvic girdle. So what makes up the pelvic girdle? We have two paired hip bones, or coxal bones, they're also referred to as, and the sacrum. So we've already gone through the sacrum, which is part of the axial skeleton, but this is how the pelvis attaches to the vertebral column is through the sacrum. And so the two hip bones unite or kind of attach anteriorly with the pubic symphysis. Okay, so we're at the pubic symphysis. Okay, so we talked about the pubic symphysis a little bit as being made up of fibrocartilage, and that's one of the few places we see fibrocartilage in the body. And then we articulate posteriorly with the sacrum. So the ilium, which is part of the hip bone, articulates with the sacrum. And that's going to create the sacroiliac joint, which a lot of people have trouble with because of all those compressive forces and the body weight going through there. And when we talk about the pelvic bone or the hip bone, we're really talking about three separate bones that come together to create one hip bone. Okay, so we kept saying ilium, so ilium is one of the three, and then we have the pubis and the ischium, and I'll show you where they separate before. You can kind of see here, so pubis is kind of this region right here, and then the ischium is the lower region right here, and the ilium makes up the whole wing there. So if we look at just one hip bone, this is what it looks like, separate from the pelvis. We see some special structures. So if we notice, there's kind of two either holes or cups. So one is an indentation, and that's the acetabulum. So that's where the head of the femur is going to articulate and create the hip joint. Now we can't get that confused with this giant hole, which is called the obturator foramen. Okay, and the acetabulum is the true hip joint, and that's where all three hip bones come together. So we have the ilium, the ischium, and the pubis that all come together at the acetabulum. And the obturator foramen is just really an area of attachment for large muscles. So it has a tendinous connective tissue covering over it in the living skeleton. So in the dead skeleton, you can actually create a hole there, or it creates a hole when all the soft tissue is gone. So I know it seems like maybe that should be the hip joint, but it's really the acetabulum that creates the hip joint. So now let's talk about these regions of the hip bone individually. And the first one is the ilium. So it's the largest portion, and it creates kind of this large flaring wing. So it forms really the superior region of the hip bone. Lots of big muscle attachment there, the gluteals included, and it articulates with the sacrum to form that sacroiliac joint. Okay, so what are some landmarks that we're worried about on the ilium? So in blue, again, I have the projections, so the things that are coming out at us, right? And then in red, I have the depressions. So if we look at the giant wing, right, so it creates this wing-like structure, and the crest of that wing we call the ala, okay? So that's kind of that whole wing. And then we have the line that it creates, which is the iliac crest. So that's just the line there. And the iliac crest is really when you place your hands on your hips, right? That's what you're placing it on, is that iliac crest. And then you have some spines. So there's going to be a posterior and inferior spine, okay? And then there's a superior and inferior spine. So you put those together, and I know it seems like a mouthful, but you have a posterior superior iliac spine, okay? Then you have a posterior inferior iliac spine. And then on the front side, you have an anterior superior iliac spine and an anterior inferior iliac spine. So there's just these little bumps, and you have to just know which side is going to be anterior versus posterior, okay? And that's going to be told by a couple of things. So we know we're looking at a lateral view in this picture because we can see the acetabulum. If you can't see the acetabulum, then you have a medial view, okay? And then you just have to orient your hip bone with the other structures as well. So that'll make more sense kind of when we go through the pubis and the ischium, okay? So we have some depressions as well, okay? So we have the iliac fossa, which we have to go to the medial view for that. So that's this big indentation right here on the medial side of that wing, okay? We have the auricular surface. So the auricular surface is going to be what is going to articulate with that sacrum to create that sacroiliac joint. And we have the greater sciatic notch. Okay, so this looks like a big curve right here. Okay, and that's the greater sciatic notch. Okay. And the greater sciatic notch is one of the ways you can tell what is posterior and what is anterior. So the greater sciatic notch is always going to be on the posterior side. So here it is on our other image right here from the lateral view. So that's always going to be the posterior side for that greater sciatic notch. Now let's talk about the ischium. So the ischium is in green, okay, and it's going to form our sit bone. Okay, so when you sit down in a chair, you're sitting on the ischial tuberosities, and that's the strongest part of the hip bone, because you can imagine, right, if you're holding all your weight on the ischium right there as you're sitting down, it's got to be fairly robust, okay? So let's look at some of these important structures. There aren't as many on the ischium as there are on the ilium, okay, but we do have some projections. So just under that greater sciatic notch, we have the ischial spine, okay, so that's a projection. It looks like a little notch right here, okay. Right under that is the lesser sciatic notch, so that's an indentation. So remember, we have a greater and now lesser sciatic notch. And then we have that sit bone, which is the ischial tuberosity. And if you look, it's kind of roughened surface, and the bone itself is quite thickened through that area. So that is the ischial tuberosity. So the last part of the hip bone is the pubis, and the pubis makes up the anterior region of the pelvis. If you kind of think about it, the ilium makes up the superior portion, or kind of posterior, and the ischium makes up the inferior portion, and then that pubis makes up the anterior portion. And the whole pelvis kind of lies in a horizontal position when it's in anatomical position, which can be kind of hard to appreciate unless you look at it kind of in the whole skeleton. And so what are some important things about the pubis? Well, it makes up the pubic symphysis, and that's where those two pubic bones join together on the anterior side. And it creates a joint there with fibrocartilage. And then another thing about the whole pelvis, really, but the majority of it is made up by the pubis, is the pelvic brim. And the pelvic brim is going to be important when we talk about a little bit about childbirth, but it's really just this superior portion that creates this kind of cup of the pelvis, okay, and that's the pelvic brim. And then the pubic arch is going to be the creation underneath the pubic symphysis and with the ischial bones as well. And essentially the pubic arch helps us to determine the sex of the skeleton. So if you have the pelvis intact, you can actually tell whether it's a male or female skeleton just by looking at the pelvis. And it does have a projection, which is the pubic tubercle, but don't worry too much about it for this class, okay? So if you look, it's in red down here. So this is kind of the anterior portion of the hip bone. So another thing that comes into play when we're talking about the pubis and the pelvis altogether is the childbearing structures. So we said that that pelvic brim is going to be important. And so when we look at the entire pelvis altogether, we can actually divide it into two different regions. And it's called either the false or greater pelvis and the true or lesser pelvis. So the false pelvis is really just the iliac, the wings of the iliac bone, and it's really all just for muscle attachment. So if you think about why it's called the false pelvis, is because it doesn't hold any viscera. So there's no pelvic organs contained within the false pelvis. So it's just for muscle attachment. It's kind of on the outer edge. And then the true pelvis is kind of inferior to the pelvic brim. So the pelvic brim delineates between the false and the true pelvis. So the false pelvis is in gray in the picture, and then the true pelvis is in orange. And if you notice, there's the pelvic brim line that's delineating between the two, okay? And so the true pelvis is what holds all the pelvic organs. And it's also important during childbearing. So when the child has to go through the pelvis to get out of the body, it's going to have to go through the pelvic outlet. Okay, so the pelvic inlet is delineated by that pelvic brim, and then the outlet is delineated between the coccyx and the pubis. Okay, that pubic symphysis. And essentially that's the direction that the kid's head has to go, right? So this is really the margin of that true pelvis, is that pelvic outlet, okay? So false is just muscle attachment, and true is holding pelvic organs, including possibly a child. So we already said that males and females have different pelvises, or there's a way to actually identify a male versus a female pelvis. And one of those ways is using that pubic arch. So in the female, it's a lot wider of an arch. If you talk about kind of an angle, right, that the pubic arch is creating, and the angle is more acute in the male, okay? There's obviously some differences just looking at the pelvis as well. The female's is much wider, right? Those ilial wings are a lot wider. The pelvic inlet is a lot larger, okay? A lot wider. And really, you know, the female pelvis is supposed to be for childbearing. So if you actually look at the size of that pelvic, the true pelvis, it's a lot larger in the female than it is in the male. And that makes sense, right? You're trying to accommodate a child in the female pelvis compared to the male pelvis. So now let's talk about the lower limbs. And again, we've got a left and a right lower limb. So we've got the same bones in each. And the lower limbs have to be much more robust. So the bones have to be bigger, more strong to carry the entire weight of the body, right? because we are a biped species, so our lower limbs are carrying our entire body weight. And just like the upper limbs, we have 3 regions. So we have a thigh, a leg, and a foot. Okay, so let's start looking at those different regions. So if we look at the thigh first, this is really just the region between the hip and the knee. And the only bone that makes up the thigh is the femur. And it is just like the humerus of the upper limb. So it is the longest and strongest bone, not only in the lower limb, but also in the entire body. So it's the biggest bone in the body, very robust, very strong, and it's going to articulate with the hip bone at the acetabulum to create that hip joint. Okay, and it's a ball and socket joint, and we'll talk more about those joints in the next lecture. So let's look at some important structures of the femur. So we have the head and neck, so they're projections, right? And then we also have some other very large projections on the femur. So just like the humerus had the tubercles, in the femur we have trochanters, so a greater and lesser trochanter. And then if you look at the distal end, we have a medial and lateral condyle and epicondyle. So the condyle is going to be the most distal, and it's a rounded kind of smooth surface, and that's what's going to articulate with the tibia for the knee. And then if you look just above the condyles, you have these little projections on the sides, which are the epicondyles. So epi kind of just means above. So they're right next to and above the condyles, okay? And the condyles in the humerus, because remember we had epicondyles in the humerus, but in the we didn't have anything called a condyle, and that's because they had specific names. So if you go back and you remember the capitulum and the trochlea, those are essentially the condyles of the humerus. They just gave them special names, okay? And we do have some depressions as well. Okay, so we have this little depression in the head of the femur called the fovea capitis, and essentially there's a little ligament in there that is for blood supply to the head of the femur. Okay. And then at the distal end, we have the intercondylar fossa. And the intercondylar fossa is really only seen on that posterior view. So again, it's a way to orient yourself on the femur to maybe tell you if it's a right or left femur. And there's a lot of muscle attachments on the femur, obviously, right? We've got a lot of thigh muscles, a lot of big muscles. And I'm not going to ask you guys all of these muscle attachment locations, but just to kind of give you an idea, and you'll see it in the lab, is the gluteal tuberosity, which is essentially kind of just these lines right here, kind of crests, okay? And then they kind of come together to form the linea aspera, which is just kind of a line that comes down the back side of the femur. And then they split to become the medial and lateral supracondylar lines. So they kind of come down, follow down to the condyles, okay? So again, lots of muscle attachment on the back side of the femur for a lot of these extensor muscles. Now the patella is part of the knee joint, right? So it's on the anterior aspect of the knee, and essentially it's just this little triangular shaped sesamoid bone, and it's even embedded in the patellar tendon that attaches to the quadriceps muscle of the thigh. And it just goes over the front side of the knee and protects that knee joint, okay? So now if we move on to the leg, right? This is the lower region of the leg, or of the lower limb, and it is only between the knee and the ankle, even though, again, just like we talked about the arm, a lot of people refer to the entire lower limb as the leg, right? But in anatomy, when we talk about the leg, we're just referring to the region between the knee and the ankle. Okay, so the upper region is the thigh, the lower region is the leg. So we have two bones in the leg, just like the forearm of the upper limb. And this is going to be the tibia and the fibula. And we said there was an interosseous membrane between the radius and ulna. We have an interosseous membrane between the fibula and tibia. You guys are going to do it too. So just remember, tibia and fibula. So it's not tibula and fibia, okay? So again, that can be confusing. And the tibia is the stronger, larger bone of the two, and the fibula is a little more flimsy, which I think of as L for fibula, is a little more flimsy, so smaller, thinner bone. Okay. And so let's start with the tibia. Okay, it's really the one that's bearing all the weight from the femur. So the fibula really has no weight-bearing function. It really is just there to stabilize the ankle. So the tibia is the only one that's going to articulate with the femur to create that knee joint. Okay, and we have some projections. So we have a medial and lateral condyle. Okay. Just like condyles of the femur, okay? They're just a little bit different. They're a little more flattened on the top. So they have an articular surface on the top that is going to articulate with the condyles of the femur. So these condyles are a little bit different, less rounded, a little more flattened. And we do have a tibial tuberosity, which is your shin. So if you feel your shin bone, right, it's something you can really feel, and there's like a little projection up at the top of the shin, that's your tibial tuberosity. And that's a big attachment for that patellar tendon from that quadriceps muscle. Okay. We do have a medial malleolus as well. So if you look at the distal end, kind of like a styloid process, okay? So this is called a medial malleolus. Okay. Of course, they can't just use the same names, right? They have to pick something new. It's a little bit larger than a styloid process, right? So a little bit different, but kind of same area, right, on the bone. And then you have your shin, right? And that's called the anterior crest or border. Okay, and that's really what you feel when you feel your shin bone, because there's really no muscle over that region, and we'll talk about that when we talk about muscles. So you actually are really feeling the bone right under the skin there, so which is why you can feel it so well. Now the fibula, like I said, is this very flimsy like bone, and it really has nothing to do with the knee joint, but it does help to stabilize the ankle joint laterally, okay? And we really only are concerned about a couple structures. So it has a head. So the head of the fibula is what is going to articulate with the tibia proximally. And then we have the lateral malleolus. Remember, we had a medial malleolus on the tibia. Now we have a lateral malleolus on the fibula, which is going to support that ankle from rolling over to the lateral aspect. And there's really no direct joint involvement of the fibula in either joint. It's just going to help stabilize the ankle. So let's just review the leg joints a little bit. So you have the knee first, which that tibia is going to articulate with the femur at the more proximal end. And then at the distal end, it's going to articulate with the talus, which is part of our tarsal bones, right? Our tarsus, which is our ankle. And when we talked about the fibula, we said it didn't really contribute to the knee joint, but it really helps to stabilize the ankle joint, even if it isn't part of the ankle joint itself. So finally, let's get to the foot, and the foot is pretty straightforward, right? It's very similar to the hand, okay? So we have a tarsus instead of a carpus, and we have a metatarsus instead of a metacarpus, and then the phalanges are the same. right? So very easy, very straightforward. So some very important functions of the foot. We said that our lower limbs carry all of our body weight, and that's all going to be transferred into our foot. So it's going to help propel all of our body weight forward when we walk. And the way the foot is shaped, it's segmented in a certain way so that we're able to adapt to uneven ground, right? So it's very different from, say, a hooved animal where you have a very rigid structure that can't accommodate uneven ground very well. We can with our arches and our segmented tarsus. Okay. So let's look at the tarsus first. And we contain 7 bones instead of 8 bones like the carpus. And really all the body weight is really going to be going into the talus and the calcaneus. So those are our 2 biggest tarsal bones and the only ones I want you guys to worry about for the tarsus. Okay, so the calcaneus is really the heel bone, and then the talus is what is going to articulate with the tibia. Okay. And the trochlea of the talus is the actual site of articulation in the ankle joint. Okay, so that's the talus, and then the calcaneus is really just what makes up your heel, right? So again, don't worry too much about the other tarsal bones. They're in kind of 2 rows as well, except you have one that kind of spans both rows. So this, you can kind of imagine, maybe 2 rows kind of like that. Okay. But again, don't worry too much about the other tarsal bones. I just want you to know the talus and the calcaneus. So the metatarsus is going to make up the majority of your sole of your foot. Okay, very similar to the metacarpal bones. And we are going to name them very similarly, except with starting at your thumb, you're going to start at your big toe. So again, you're going to go medial to lateral in this sense, okay? And the first metatarsal is really what is going to support all your body weight. So all that body weight coming through the talus and calcaneus is really going to go through your first metatarsal into your big toe, okay? And the phalanges are very similar to the phalanges of the hand. They're just smaller and less nimble than your fingers, but we're going to name them the same way. So we have 3 phalanges in all your toes except your big toe. Okay, so your big toe is very similar to your thumb. You are missing the middle phalange in your big toe. Okay, so you only have the proximal and the distal. Now, another important thing about the foot and why arches are so important is that they are what are going to help recoil and propel our body weight forward. And we actually have 3 important arches. So if you look at our picture here, we have 2 that are going in the longitudinal section. So we have 2 that are going to go, heel to toe, and then 1 that's going to go transversely or across the arch of your foot. Okay, so you don't need to really remember the names of the arches, just remember why they're important. So they're really important for helping us propel all that body weight forward. Okay. And just like we said, the importance of the shape of the foot to kind of accommodate uneven grounds, the arches are really maintained by the tarsus, so the shape of those tarsal bones, as well as a lot of tendons and ligaments in the foot as well. And so some people just have flatter feet than others, and that can create, back problems, things like that. So arches are really important for posture and mobility. So last but not least, we have just a couple disorders of the appendicular skeleton that we'll talk about. And one is hip dysplasia. So that's really where the head of the femur slips out of the acetabulum. And so this is an infant radiograph here. You can tell because the head of the femur is just this little knob right here. So remember when we were talking about bone tissue and bone development and those growth plates, you can even tell the difference between all those hip bones as well. They're completely separate because those growth plates haven't come together yet. Like you can see the ilium right here, you can see the pubis and the ischium. They're superimposed, so it's hard to tell which is which. But on this left image here, you can see that the femur is not in place, right? The femur is not in the acetabulum. So here's our cup of the acetabulum, and that head of the femur is completely out, okay? Whereas the other one is kind of within that acetabulum, right? And this is common in dogs as well. So dogs can get hip dysplasia, especially certain breeds. And another disorder is called clubfoot. And essentially what happens is the soles of the feet turn medially. Okay, so the legs don't grow straight, and it really affects the foot and the foot positioning. And a lot of people that have club feet have to undergo many surgeries to try to correct the angle of the foot. So here are the learning objectives for this lecture. A lot less bones in terms of, number. Obviously we have left and right of everything, but a lot less compared to the axial skeleton, and a lot of information. So we'll finish up this unit with chapter 9 and the joints next lecture. And here are some review questions as well if you would like to go through those. I hope to see you guys in office hours. Thanks a lot.